Hello and welcome, everyone. I'm Emily Bell, Director of Colorectal Cancer Interventions for the American Cancer Society National Colorectal Cancer Roundtable. Thank you, everyone, for joining us for today's latest Blue Star conversation. So first, I want to go through just a bit of general housekeeping so that you can follow the flow in our format. The presentation portion of the session will be recorded, and the video recording will be posted to the NCCRT website following our presentation. All participants have the option to come off mute to allow for a small group discussion later in the program. So please make sure your microphone is muted until that discussion portion. If you have video capabilities, we encourage you to be on camera when we get to the discussion. It always helps it to make it feel more interactive when we can see each other. And so we can all get to know each other a little better. Please put your name, where you're from, and which organization you represent in the chat. And so that we can assign you to a breakout group with others outside your organization, please take a moment to add your organization name to your screen name by clicking the three dots at the top right of your video tile. You click on rename, and then you can add your org name after your name. And I actually realized I did it this morning, but then it was bumped off. So I'm going to do it in a moment, and then you can see what it looks like. Okay, so again, it's the three dots at the top right of your video tile. Click rename and you can add your organization. Great to see that we have so many participants today. And finally, we'd greatly appreciate it if you take a couple minutes at the end of the program to complete the evaluation so that we can learn and incorporate your feedback. So before we get started, we'd like to get a sense of your thinking around a key element of today's conversation. Please take a moment to share your response to the following question. What is the greatest barrier that health centers face in implementing colorectal cancer screening for average risk patients starting at age 45? So if you select other, please just limit your response to 1 or 2 words so that we can aggregate the results and share that later in the session. We'll have the opportunity to discuss the results once we get to the discussion portion. We'll pause to give everybody a moment to complete the poll. And we certainly debated allowing everyone to select more than one, but we went with one so that we could, more quickly look at the results and identify those top barriers. But great, thank you so much for sharing your responses. Okay, so let's move to the next slide. So if you are new to our Blue Star Conversation series, you're probably starting to get the sense that the format is a little different than a typical webinar. Each Blue Star Conversation is hosted by one of the NCCRT's strategic priority teams and features a short presentation followed by small and large group discussion among the attendees. It's a great way for everyone to not only hear from our presenter, but learn and engage with our strategic priority team chairs as well as other attendees. And we began offering this program because we found a need for providing our members with opportunities to discuss important topics outside of our annual meeting. As a reminder, this series is only open to our NCCRT members and CDC grantees, as well as a few special invited guests. So for our objectives today, we'll engage with the Community Health Center Strategic Priority Team. We'll learn about the latest data, research, and resources to support increased colorectal cancer screening in health centers with a focus on the newly eligible 45 to 49-year-old age group. We'll discuss potential opportunities and challenges and share our top takeaways. So we're excited to hear your thoughts and feedback. So it's important that you're geared up and ready to participate in these discussions by coming on camera and off mute once we get to that discussion section. Next slide. And I'm pleased to introduce our Community Health Center Strategic Priority Team co-chairs, Dr. Gloria Coronado, PhD, who's the Distinguished Investigator Mitch Greenlick Endowed Scientist for Health Disparities with the Kaiser Permanente Center for Health Research, and Jim Hotz, Dr. Jim Hotz, Clinical Services Director with Albany Area Primary Healthcare. Both Gloria and Jim have been engaged with the NCCRT for many, many years, and we're so grateful to them for their many contributions to our work. So with that, I'll pass the baton to Gloria to share with us a bit more about the Strategic Priority Team and the work that this group leads.
Wonderful. Thank you for that introduction. And unfortunately, Dr. Hotz could not be here today, but I would like to share with you just the objectives of the strategic priority team that's focused on community health centers. So our goal is to identify and act on opportunities for NCCRT to advance efforts to increase colorectal cancer screening delivery within community health center settings. So specifically, we're charged with identifying and sharing implementation strategies to increase colorectal cancer screening, develop project ideas focused on health center implementation strategies, and promote ongoing dialogue. So we really serve as a conduit for dialogue and interactions where we can help shape the direction of NCCRT, and NCCRT really provides a nice national platform for us to disseminate and distribute our work. As you can see, the rates of colorectal cancer screening in community health centers or federally qualified health centers nationally was significantly impacted by COVID-19. So you can see that in 2019, we reached the peak rate of 45.6%, and that dropped by over 5 percentage points in 2020. And you can see that there's been some incremental increases over the course of the last 2 years, with the most recent data showing a 42.8% colorectal cancer screening rate. And this is among individuals who are ages 50 to 75. I think one thing to note is that even though that looks like a decrease from the peak rate of 2019, that the number in 2022 is actually larger than it was in 2019. So in 2022, the number of people who were screened for colorectal cancer was 2.74 million. And 2.77 million, and in 2019 it was only 2.74 million. So there's been a slight increase in the total number of people that this percentage represents, and that has to do with the fact that many of these health centers have really increased their patient volumes, particularly since Medicaid expansion is occurring, and also with the new rules around redetermination during COVID, and so that's allowed more people to stay on Medicaid. Oh, thank you for putting those numbers in the chat, Emily. So I just want to kind of give a brief moment or give you an update on some of the more recent resources that this strategic planning team, along with NCCRT and some external collaborators, have really helped develop. So many of you hopefully are already familiar with one of NCCRT's signature resources, which is the STEPS Guide for Increasing Colorectal Cancer Screening in Primary Care. So this guide was updated in 2022, and now just recently this summer, there's been 10 case studies that were released that provide information and detail, including the work of 7 health centers. It offers a goldmine of resources for health centers, including dozens of pages of sample tools and templates, so there's no need to recreate the wheel to implement new strategies to increase colorectal cancer screening. So if you haven't checked out the new STEPS guide, the link is here, and those 10 case studies is a real treasure. I'm also pleased to share that the MailFit Implementation Guide, an online course, is now available. And this is a resource created by the National Association of Chronic Disease Directors with support of my team at the Center for Health Research. These resources provide a roadmap for how health centers and health systems can design and carry out MailFit outreach. So again, this resource is available on the NCCRT website under resources. And now I'm pleased to introduce our presenter today, Dr. Daniel Reuland. Dr. Reuland is a professor of medicine at the University of North Carolina School of Medicine. He's also program director of the Carolina Cancer Screening Initiative at the University of North Carolina Lineberger Comprehensive Cancer Center. Dr. Reuland today will be talking about some of his NCI-funded work through the Moonshot program that he completed in collaboration with Dr. Megan O'Leary and other members of his stellar team at North Carolina. Dr. Reuland, we're really looking forward to hearing about some of your recent research, so I'll hand it off to you.
Great, thanks so much, and really happy to be here. Thanks for inviting me. And a shout out to Megan O'Leary, Dr. O'Leary, now Dr. O'Leary, who's my close collaborator on this work. To share my screen here. Let me know if you can see it.
Looks great.
Okay, so I'm going to share with you, as Gloria said, some work that we've done here in North Carolina. That is really this is a smaller study as part of a larger mailed fit testing program to improve colon cancer screening in community health centers. This is also work that is really needs to be taken in that context, and I'll show you a little bit about the larger program as we move forward. The citation for the paper is here if you want to actually look at it or get into the details, but I'm also happy to answer questions. For some reason, my slide isn't advancing. I think I'm getting waiting room notices here.
We see the guideline recommendations on our screen.
Yeah. Okay, so anyways, as you all know, in May of 2021, the USPSTF updated their CRC screening recommendation statement to include this age group 45 to 49 years old. I don't think this is news to most people on this call, but one reminder, I think that's one thing to keep in mind, is that it is a B recommendation, meaning their take on the balance of benefits and harms is a little bit more of a close call compared to 50 to 75. And I think it's important for us to make sure that we do a good job of screening 50 to 75 in addition to, and perhaps even a higher priority. If we're not doing well in the slightly older age group, we may displace some of that screening. And it's a much higher risk disease as we get into our 50s and 60s. But ideally, we're able to screen everybody now who's recommended. For some reason, it's not advancing. There we go. So some additional background, I think folks know this, that it's effective to screen people for colorectal cancer at ages 50 to 75. Community strategies with high CRC burden and low screening rates are particularly important for us to focus on, but I imagine that's why most of us are on this call, is because we're very interested in serving these communities where screening rates are low. Not much is known about mailing fit to this younger age population, this newly eligible 45 to 49-year-olds. So that's why we did this study, this sub-study. These were the main objectives. We wanted to just assess fit uptake in this population of 45 to 49 years old after mailing fit kits with some reminders. We wanted to test the effectiveness of two different envelope types also. Some of the work that, really there was some background work that Gloria and others have done where we've tried to identify what's not known. And one thing that hasn't been studied is what can we do to get more people to open the envelopes for mailed fit and get them to engage. So we were testing two envelope types, and we'll tell you a little more about that. The third objective was really just to step back and say, well, what happens if we mail to all 45 to 49-year-olds in a population in a given community health center clinic? And what would happen to the CRC screening rate, sort of like a UDS type measure. So we'll go over those two. As I noted, this is part of a larger moonshot project that we call SCORE here in North Carolina, and that's really looking at how we can centralize or support mailed fit outreach to increase CRC screening. This is the sort of the one snapshot of the bigger project. We're mailing in two regions of North Carolina to two terrific partner community health centers. One is Blue Ridge in the western part of North Carolina, that's mountainous. And then the orange region is the Roanoke-Chowan Community Health Center in the eastern North Carolina that happens to be an area with very high incidence and mortality of colorectal cancer. So this project was because we had limited resources. We were in the middle of a big project, and the guidelines changed to include this age group. We said, well, let's focus down in this higher risk area. And we picked their largest clinic at the Roanoke-Chowan Community Health Center to do this project. Again, this is just sort of an overview of the Moonshot program for colon cancer screening, including all these different locations where they're testing different kinds of interventions, including Dr. Coronado's up there in Oregon. So this is kind of our basic timeline. We adapted the materials for this age group, which didn't require a lot, but there's some special wording that we were using to focus on the high risk in this particular region, and also that the guidelines had changed because we thought people would be somewhat surprised to be hearing about this because it's so recent. We mailed the fit kits. This is about 1.5 years ago, and then we looked really just at uptake, and I'll tell you some of the results. But first, these are the 2 envelopes we tested. The one on the left is what we called our enhanced envelope. It's a padded envelope. Feels like it might be something from Amazon or something. But it has a tracking label. It has a reminder sticker on the back saying this is a message from your doctor. The reminder or the message sticker also has the clinic logo. We're trying to make sure it seems like it's coming from their clinic. And then the plain envelope is much cheaper, not padded. Does have the clinic logo and the return address, but otherwise is, pretty ordinary. This is the basic study that we did. We identified all the community health center, all the patients at this one clinic who were in this age group who were active. And we defined active as having had a clinic visit in the last 18 months. And then we were able to exclude, using an EHR query, those who were already up to date with screening. We also excluded the few who were not at average risk. So maybe they had ulcerative colitis or inflammatory bowel disease and would not be eligible for FIT. And then a small number had comorbidities or were too sick for screening. This left us with 344. And then we ended up looking a little more closely, as probably many of you know if you work in community health center context, that you can't always get super accurate data just from these larger EHR queries. Sometimes you have to actually look and make sure you've got the right population and that they're not up to date with screening if you're going to be recommending screening. And at that point, that's where we randomized them to either get the envelope type 1 or 2. There were 316 who were randomized. And this gives you an idea of the demographic breakdown of the population we were looking at this community health center. This community health center serves a largely Black African-American community in Eastern North Carolina. And then as you can see, that was 58%. As you can see on the right with insurance type, a lot of self-pay patients, particularly in this age range, because, for the most part, not Medicare eligible. And at that time, North Carolina had not expanded Medicaid, which they're working on. So here's the results. We mailed fit kits to 316 individuals and got back within 60 days, 54 of them for a return rate of 17%. 3 were abnormal, and all 3 of those got a colonoscopy with some guidance from our navigator that's also part of our program. When we looked again at 6 months just to see, there were really only a few stragglers. As you can see, the number went from 54 to 57. So most people are going to do this. If they're going to do it, they're going to do it in the first 60 days. As far as the returning, comparing these 2 envelope types, we did see a difference. We weren't sure it would really matter, but we did see a 21.5% return rate on the enhanced envelope compared to 12.7% in the plain envelope, and the difference was statistically significant. So the next thing was to just step back and say, well, that's fine as a research study, but what about what happened to screening rate overall in this population? Because community health centers are really going to be interested in that, especially as it becomes a measure that they need to report. So we really compared. What we wanted to do is on day 1 say, what's the screening rate in this population of 45 to 49-year-olds, expecting that it would be pretty low, but not zero. People get colonoscopies for all kinds of reasons, including symptom evaluation. And then we just looked at it again. So this is really the population now, the top of the funnel, as we sometimes call it, that implementers may actually be interested in. These are our patients who we really need to reach and get screened. Well, here's what we found. At baseline, we found 26% of this population was had some kind of colorectal cancer screening. Most of them, I believe, had colonoscopy sometime in the prior 10 years, so they were technically up to date. Oh, excuse me. And then if we look 6 months later after the mailing, it had gone up to 42%, so an increase of 16.4 percentage points in the screening rate, showing that, you know, you do get a bump if you do this kind of intervention. It's not the only intervention to get to 80%, but it can move the needle. So our overall findings are that a subset of patients in this age range will be willing to complete a fit kit and return it mostly within 60 days. Our findings also suggest that a more visually appealing mailer can really help boost fit uptake. It's a small study, you know, others larger studies testing maybe some different messaging need to be done, but for now, it's not like it's that much more expensive to use the enhanced envelope. So if you can afford it and if you want to do this, there's some evidence to support using the padded envelopes with the tracking stickers. And overall, we think mailed fit outreach can be used to support adherence to these updated task force screening guidelines. These are limitations. As I said, a small study, just one FQHC clinic. We didn't test many options. As I said, more research needs to be done. And that the clinic level screening, so that the latter part was really not done with a manual scrub, but really just with the query. So it's an estimate, but I imagine for UDS reporting, that is also how things are done, usually with the HR queries. Our thoughts on this, and going into the discussion, you know, I think this suggests the importance of working with community health centers to really build trust and leverage some of these interventions. At our Cancer Center in North Carolina, we are really trying hard to grow these partnerships. And I also think that, although it's not stated here, I think this, you know, the letterhead, the stickers, the things that y'all may have talked about in other webinars, but building trust and making sure that the patients who receive these interventions feel like it's coming from their community health center, a trusted source, I think is one way to really boost engagement. So that's, in a nutshell, the study that we've done. Thank you to our team members on the left that are listed there. And then our contact information for Dr. O'Leary or myself is on the right. And that's all I have. So I will turn it back to Gloria. And thank you all for inviting me to come present this study.
Thank you so much, Dan, for such a thorough and thoughtful presentation. We are going to break into small groups, but before we do, let's just break and see if anybody has any clarifying questions. I think somebody's going to monitor the hand raises or the questions in the chat, and certainly people can come off camera. But I'll start by asking the first question. So I really enjoyed seeing the findings of like the enhanced envelope and the standard envelope. I just wondered, like, what was interesting is that you also included the tracking label on the enhanced one, and I just wondered to what extent you thought that added value. So was there ever situations where you remailed a kit that didn't arrive at its destination? So would you recommend that programs?
Well, that's an interesting question. You know, that came up, that little piece of the intervention actually started with our larger trial that we're working on, mailing fits, a couple thousand fits to 50 to 75-year-olds. But during COVID, the Postal Service seemed to have some challenges, and we weren't really sure everything was getting where it needed to be. So that was something we added during COVID to make sure we could at least tell that our fit kits were being delivered. You know, it doesn't mean they opened it or anything like that. And so we decided, well, you know, maybe it just makes it feel a little more important. Like, oh, wow, they're like tracking this, you know, and then, you know, using the logo and a padded envelope that, like I was joking about, but it feels like, oh, maybe it's something, you know. It's from Amazon. I don't know, so whatever you can do to kind of get people to sort of pay attention to it enough to at least open it. And then, obviously we don't have a way to drill down on that, but that was, it's sort of, we stumbled into it, but then we decided to include it in the experiment.
Great. Any other questions? Not, I'll hand it back to you, Emily.
Great. Well, thank you so much, Dr. Reuland, and to Gloria too. That was fantastic. So in a moment, we'll move everyone into breakout rooms at random. We'd like for you to use this time to engage with your peers and discuss what you learned in the presentation. We encourage you all to come on camera, and each breakout group will have 20 minutes to review the topic and discuss the questions. Please choose someone to take notes and share back with a larger group. And in your discussion, we ask you to consider these discussion questions. So first, what challenges and opportunities do you see for health centers as they move to screen patients starting at age 45? Second, what are some potential solutions to address the top barriers to screening at age 45 identified in our poll? The top three were lack of public or patient awareness, not enough staffing, and resistance from patients. And then third, in addition to the recently released resources, the STEPS guide, the MailFit guide, and online course, what other tools, resources, and other support would be helpful for health centers in their colorectal cancer screening work? So you certainly have your discretion. So if your group wants to focus on one question, that's fine. If you get to all three, that's great. There's flexibility there. So please remember, we'd like this to be as interactive as possible. So please come off of mute and on video when sharing with your group. And then we are also about to place these questions into the chat. Once you go in the breakout, you're not able to see the same chat. It's just your breakout chat. So if you don't mind, please just copy the chat questions that you see there so that you can bring those over and then paste them into your breakout room. So everybody, please take a moment to just do a quick copy on those questions that you see, starting with what challenges and opportunities. All right, so after the 20 minutes, we'll return to the main room where each group has the chance to share their top takeaways. Does anybody have any questions?
I think Brenda does, but she is muted. I see your mouth moving, Brenda. Oh, you are still muted, Brenda. I'm sorry. Can you type it into the chat for us?
Brenda, if you'd like, you can email nccrt@cancer.org, and we'll be sure to get an answer to your question if you're having trouble entering that there. Okay, well, I think we can go ahead to break out, and we'll look forward to seeing you back in about 20 minutes.